everyone, and welcome back to the journey. Today, as you can see, we're going to be talking about respiratory system tuberculosis, alright, also known as your TB. So with tuberculosis, it is a highly communicable disease caused by the microbacterium tuberculosis, okay, hence the word tuberculosis, okay. Also, it primarily affects the lung parenchyma, but is not limited to the meninges, which is part of the brain, the kidneys, the bones. You have your lymph nodes, intestines, peritoneum, joints, and your liver. All right. Also, you have the aerobic bacterium, which are mostly going to be seen in the upper part of your GI tract. Your respiratory tract, just because that's where you have the highest content of oxygen. Okay. Also, you have the development of mutations. When with any bacteria, so you always have the risk of having multi-drug resistance. Okay. So sometimes tuberculosis can go into a strand where it mutated and now you have multi-drug resistant TB, which pretty much just means that it's very, very hard to kill off just because it's been resistant to so many different bacteria, so many different antibiotics that now they have to, kick it up a notch just to kind of manage the disease process, okay? So with that said, you also have your acid-fast rods. And with your acid-fast rods, they grow very slowly. But once the bacilli reaches a susceptible site, it then starts to multiply, okay? And it is sensitive to heat and ultraviolet light. Now we have the disease progression. Now with the disease progression, this kind of gives you a better understanding of how it's deteriorating the respiratory system, okay? So, of course, it's droplet, and the droplet enters the lungs, and the bacteria form a tubercular lesion. Once that lesion is not present, the defense system within our bodies, our immune system, right, our defense mechanism, encapsulates that tubercle, right? And in it encapsulating that tubercle, it helps to prevent the spread. Now, there's times where the body may not detect it as early, and it's not encapsulated. And when it's not encapsulated, then that's where it has the possibility of leading to the lymph system. And then from there, it's going to create an inflammatory response, also known as your granulomatous inflammation. All right. You also have your primary lesions may also become dormant, right? So that lesion that's there, it's not spreading or doing anything, but it's just staying and being dormant. And once it comes in contact with that same bacteria, then it can start activating up again. Okay, so it can be dormant, and then when it's re-exposed to that bacterium, then all of a sudden now it spreads, okay? Now, the active phase TB, okay, which is the worst possible thing that you can have, because this is when the bacteria is alive and effect, okay? It is doing everything that it possibly can do because it is active. So with that, you will start to see necrosis, which is pretty much the dying off, right? And captivation in the lesions, which is lead to rupture and the spread of necrotic tissue and damage throughout the body. Okay, so remember, TB is not just limited to the lungs. Of course, it's more prone to the lungs, and that's where you will mostly see it occur, and the damage will occur. But it also can occur throughout the different parts of the body. And if it is in those different parts of the body, it can cause necrosis to those areas, and of course, necrosis to a tissue or an organ. Then eventually cause organ failure or destruction and malfunction, and then the body's not able to work the way it's supposed to work. Alright, so now we have the transmission of TB, and with TB, the main transmission route is going to be airborne, okay? So with the airborne route, it's pretty much droplet infection, and it's when a person releases droplet nuclei through either talking, coughing, sneezing, laughing, or singing. Alright, and then the larger droplets pretty much settle to the ground, where the smaller droplets are suspended in the air. Okay, and that's what causes when a person comes into the room and they've been in the room long enough, right? Those droplet particles that are still suspended in the air can now, once inhaled, can now affect you. Okay, so some of the risk factors that they have is pretty much a child younger than 15 years of age, drinking unpasteurized milk, and a cow that is affected with the TB infection, a low economic status, and those are people as far as minority groups, refugee groups, or your homeless people. All right. You also have individuals living in crowded areas like a prison, mental health, care facilities like assisted care facilities, nursing homes, different things like that, where you're in a crowded area constantly. Alright? Also, you have older adults that's 44 years of age, people with malnutrition, infection, immune dysfunction like your HIV or your immunodysfunction type of patient, those who have low immune system from either lupus or so, or because of medication, right? Certain medication that they have to take, like your corticosteroids, immunosuppressive medication, if they had a transplant, those are going to decrease your immune system, all right? Next, you have people who have alcohol use or IV drug users, okay? They're going to be at a risk of catching TB. And of course, your healthcare workers. Why? Because we put ourselves in these situations where we have to take care of these patients and we put ourselves at risk of contracting these different things. Of course, you know, you can protect yourself. There's different equipment that's used to protect yourself, especially with airborne. The main thing is wearing your N95 mask. Now we have our clinical manifestation, which is also known as our signs and symptoms, which is also known as our nursing assessment. So for starters, sometimes the patient can be asymptomatic, where they show no signs of the symptoms whatsoever. But at other times, you can have fatigue or lethargy, you have anorexia, weight loss, low-grade fever, chills, night sweats. You also have either persistent cough or production of mucoid or mucoid purulent sputum, which can be streaked with blood, okay? You also have chest tightness and a dull aching chest pain with cough. To add to the signs and symptoms is pretty much adventitious breath sounds and partial obstruction, okay, that may occur with tuberculosis, because again, it is affecting the respiratory system, so you may have difficulty breathing, you may have wheezing or so, diminished breath sounds, alright, so just keep that in mind. When you're dealing with respiratory problems, most of the time your signs and symptoms are going to be a dead giveaway of respiratory breath sounds, difficulty breathing, alright, those sort of things. So now we're going to go ahead and talk about our diagnostic testing. So with the diagnostic testing, you want to gather a patient history, and with the patient history, you want to know about any past exposures, the patient's origin, right, where they're from, and whether they travel to any foreign countries. Why? Because they're at increased risk of TB. Also, you have any recent history of influenza, pneumonia, febrile illnesses, or cough, all right? Also, you want to know about previous tests for TB and what their results were. And then last but not least, bacillus calmette urine vaccine, okay, which is also known as BCG. All right, and this is pretty much for those of you guys who are international or so. They pretty much give these vaccines earlier on to kind of increase the resistance to TB, okay? They do not do that here in the United States. They have banned that, so a lot of times you won't even hear about that vaccine, or you'll probably wonder what is that vaccine for, okay? So a lot of people who are international, they will know about this vaccine because they have gotten it when they were younger, and it was pretty much to a vaccination to help prevent TB or build resistance to, all right? I guess in some point in time they did research and realized that the vaccine doesn't fully prevent TB, so that's why they don't do it here in the United States. I don't know if they still do it internationally as of recently, but people from the past, if they do have this vaccine, every time they'll take the PPD testing, it will show up as a false positive, okay? And then they will have to rule it out by using other testing, okay, which I am going to get into now. So with our PPD, right, purified protein derivative, this is our tuberculous skin test, all right? And with this is measurements in millimeters, okay, of induration. And induration is pretty much means hardening, all right, hardening. So what they do is they're going to inject intradermally right above the skin 0.1 ml of this solution, and it is going to stay in the areas of your forearm, which is pretty much 4 inches below your elbow. So here, just like 4 inches below, mainly in this area here, all right? It's the key points. Also, you're going to see elevation of the skin, all right? So you're going to see a wheel that's around 6 to 10 millimeters in diameter, all right? Which is okay, that is normal to see when they initially inject you, okay? They are going to catch the results within 48 to 72 hours, after, so you want to make sure that if you're taking this test that you're able to come back 2 to 3 days after to make sure that you get the results. Anything after that, they have to void and do another one, okay? So that is the time frame, 48 to 72 hours, and they're looking for the size of the induration. A delayed reaction, that means that the person has a sensitivity to the tuberculin, all right? So I wrote here in blue so that way it can jump out at you, right? 0 to 4 millimeters means no significant. Pretty much means you're fine. There's no alarm needed or any extra precaution needed for the testing, okay? If you have 5 millimeter or greater in an HIV patient, that is significant findings, okay? So they will do other testing to make sure that they're able to rule out TB, all right? And if you don't have HIV, right, 10 millimeters or greater is significant, right, for people who are normal or have a mild impaired immune system. Now we have our positive reaction, okay? And with our positive reaction, that do not, and I put it in red, that do not mean that they have the active disease. That just means that you now have to go through another testing or another screening to make sure that this patient has it or does not have it, all right? That's all that means. So just because this test came up positive, it doesn't mean that you have TB. Alright, so we're just continuing on with the diagnostic testing, and the next test that we're going to go over is our chest x-ray. And our chest x-ray can show either active or latent TB, and with that is not definitive by as far as being able to tell you right then and there, this person has TB, this person doesn't have TB, but the presence of a multinodular infiltrates with calcification in the upper lobes do suggest TB, alright? Also, if it is active, you can see caseation and inflammation can be seen on the x-ray as well, alright? Then the next testing you have is a quantiferon TB gold test, and with that is pretty much blood sampling that they take. So it's a blood test by enzyme-linked immunosubordinate assay, and it's either sensitive or rapid test within 24 hours, okay? So this testing can be done within 24 hours. It can be less than 24, but no more than 24, all right? And finally, we have our sputum cultures of the acid-fast smear, and pretty much this test is used to see the effectiveness of the therapy, all right? So this sputum sample is taken after the medication of, taking it within 3 months or so to see, how well the treatment is going, and mainly there are negative cultures within 3 months of treatment. Alright, so now we're getting closer and closer to the most important thing that we need to know as nurses is pretty much the medical management, right? So pulmonary TB is going to be treated for 6 to 12 months, and I know you're probably saying that is a very, very long time, but you want to make sure that the whole TB is eradicated, and you want to ensure that by making sure that they're on that treatment for a very long time, because with TB, it can build resistance very easily if the medication is not for a long period of time. So just to ensure that it's all gone, you want to make sure that the patient is very compliant with the medication regimen. That is the biggest thing that you can teach your patient, is pretty much compliance with the medication regimen, okay? Just because it's for so long. Also, in current TB therapy, there are 4 first-line drugs that they like to use. And you have your INH, which is your isoniazid. You have rifampin, okay, which I put here, it turns the urine orange. That is one of the biggest things, question that I love to ask about rifampin, is that it turns the urine orange. So you want to inform your patient about signs and symptoms or side effects of the medication. So you want to let them know, hey, don't be alarmed. This medication is known to cause or turn your urine orange, but that is okay. That is something that the medication does, all right? And that's the biggest thing when it comes to rifampin, okay? Also, you have your pyrazinamide, and then you have your ethambutol, okay? Those are your main 4 drugs, but you also have your tryptomycin, okay, that can be used as well. But again, the first 4 are the main first drug of choice, all right? You can also do combination therapy where you have INH and rifampin, and they will do that at least twice a week. Then you have your initial phase. It's pretty much 8 weeks of continuation. Therapy is going to be 4 to 7 months, okay? So initial is just 8 weeks, which 8 weeks is pretty much 2 months, and then you have an additional 4 to 7 months just for continuation to make sure that it's eradicated. All right. Also, vitamin B, right, is usually going to be administered with INH. All right, because you want to prevent peripheral neuropathy. All right, so that's another thing. When it comes to INH, you want to make sure that you have your vitamin B. Also, with INH, you can use prophylactic for 6 to 12 months for household members who have been with patients who have active TB, okay? So one thing with TB, once that person has been affected and they have active TB, everyone who has been in that household is going to also have the same treatment plan. So at least you will know that you won't be alone, that you will be having this treatment therapy with the rest of your family, okay? Whoever lives in that household with you, whether it's your spouse, your children, whoever, as long as they're living in the household with you and the person has active TB, you will also be on the same treatment regimen, right? Another thing you have is your patients with your HIV with a PPD testing that is 5 millimeters or higher, okay? They're also going to be treated prophylactically. Also, people are considered non-infectious after 2 to 3 weeks, so that's a good thing. So after 2 to 3 weeks, you're still going to continue your medication therapy, but at least you know within that time frame you're no longer infected, okay, where you can pass it on to other people, all right? And then, of course, you're going to monitor your labs daily. All right, and last but not least, our nursing interventions of TB. So one main thing that we want to do is promote airway clearance, okay? Main thing is you want to make sure that the airway is clear. Also, you want to advocate adherence to the treatment regimen. So again, like I said, it's 6 to 12 months. This is not something that's 2 weeks or 3 weeks or so. This is a very long time, all right? This is pretty much almost a year, but 6 to 12 months, that's 12 months is a year, right? Of you having to be on this continuous regimen. So compliance is the biggest thing that you want to make sure that your patient has, okay? Otherwise, the treatment is not going to work. The bacteria may build resistance, and it's going to be even harder to treat the next time, all right? So you want to really stress that. Also, preventing spread of infection, okay? So the main thing is you're going to be on airborne isolation. Now, what airborne isolation means is pretty much you're going to be in a negative pressure room. The doors are going to be closed. There is going to be alarm to let people know if the disruption of the negative pressure is disrupted. So you're going to hear a ringing sound on the door itself. All right. So you want to keep the door closed, and you want to wear your N95 mask. The nurses or any healthcare provider or workers, you want to make sure that you're wearing your N95 mask. Okay. Also, the room should have 6 exchanges of fresh air per hour, and it's ventilated outside. So pretty much what happens is the negative pressure is sucked up into the room, and as it's sucked up, it goes into a vent, and that vent pretty much distributes to the outside air, while it brings air from the outside in. Okay. So again, you may wonder, why are we bringing the droplets outside? By the time they get outside into the community, it's so vast that eventually no one is going to get infected because it's lingering out into the atmosphere, and eventually then it will drop down. Remember, the larger droplets already drop to the floor. The smaller ones dispense in the air for a while, but after a while it will drop down. So the likelihood of anyone getting TB just out in the community is a slim chance. Okay, so that's what happens. Negative pressure is in the room. It takes whatever is in the room and puts it up into the ventilated air, out into the atmosphere. All right, in case you guys wanted to know. Also, main thing, thorough hand washing. Okay, cannot stress that enough. You want to make sure that you're telling your patients, that you're telling your patients' family members, and you as a healthcare provider or worker, you want to make sure that you're hand washing, right? Because you don't want those droplets to get on you as the patient was sneezing, or the clothes that they're wearing, right? And you just walk outside and you forget to wash your hands, and you touching your face, and you're breathing in all of those small droplets. So hand washing, hand washing, hand washing, okay? Also, the patient is required to wear a surgical mask when they're leaving the room. So you may say, what is the protocol when we have to take this patient to the CT scan, or we have to take this patient, for a procedure of some sort, right? Or they have to get transferred up to another room. You want to make sure that they have on a surgical mask. That's a little bit different from the N95, but they're going to wear a surgical mask, all right, whenever they have to leave the room, all right? Also, patients can resume activities gradually. So whatever activity that they were able to do before, they're going to do that gradually. Another thing you have is adequate nutrition. So one of the biggest things is that you want to increase the intakes of foods that are rich in iron, protein, and vitamin C. Okay? Also, you want to inform the patient family member that respiratory isolation is not needed for them just because they've already been exposed. Okay? So for the family members who have already been in the room or so, you don't have to be paranoid and say, hey, put on a mask, put this on, because they've already been exposed and they themselves are getting the treatment. Okay? Also, you want to instruct the patient to cover their mouth and their nose when they have to cough or sneeze, and to put any used tissue that they have into a plastic bag, because remember, those droplets stays on that tissue, and if you just put it in the regular trash, right, without tying it up or putting it in a plastic bag, though you can now be prone, or the person who's coming in, whether the housekeeping, when you have to change the bag. So you just want to make sure that you limit the spread of the infection as much as possible. All right. Also, you have your sputum culture is needed every 2 to 4 weeks once the medication treatment has been started. And if you have 3 consecutive times that the culture are negative, then you are considered non-infectious and you're able to go back to work and do daily things that you were doing before. Also, I put in red, avoid excessive exposure to silicone and dust, because they just cause further lung damage. And again, the TB, especially if you have respiratory TB, it is affecting your respiratory system. And remember, you only get one set of lungs, and once it's gone, it's gone. So you want to make sure that you are treating your lungs carefully and that you're maximizing the best function possible. So different things that are going to harm or cause harm, you want to stay away from. Okay? Also, teaching. Teaching is very important. Throughout all your nursing interventions, you always want to be teaching. And you want to teach the patient about the medication regimen, because it is 6 to 12 months and it is a long regimen. You want to teach about compliance. You want to teach about signs and symptoms, the spread of infections, and to pretty much narrow down and, provide proper hand washing, preventing the spread from different areas, and also follow-up care, right? You want to make sure that you're following up and doing exactly what the doctors want you to do, and that you're taking the testing and sputum cultures and things like that. So you also want to teach about following up care, and that this is going to be a process that not only they but also the family members within the house will also have to go through as well. Okay, and that is it for tuberculosis. If you like this video, please give it a thumbs up. If you have any questions or comments, please leave it in the comment sections below. If you need any extra added information, please be sure to check out my description box. If you have not subscribed yet, what are you waiting for? Go ahead and click that subscribe button. And again, thank you for watching and coming on this journey.